part of the G4 Alliance. He will do a presentation about the Operative Encounters Registry. And he's going to explain in detail the work done by the G4 Alliance and its team. And I would also like to have space for Neil to introduce himself, talk a little bit about his experience, and then we can continue on with the presentation. Thank you.
Okay. Natalie, if I can share my slide from my end. Great. I hope you can all see that. It's great to join you today. For those that do not know me, I am the current Vice President of the Permanent Council of the G4 Alliance. I am a general surgeon and I work in the Democratic Republic of Congo in Africa. I am an Australian and I have been involved with the G4 Alliance since 2015. Today, I want to tell you about what is called the Operative Encounter Registry, which may have different terminology in different parts of the world. But this is the topics I am going to address today. How this fits into the strategic plan of the G4 Alliance, the background of the registry, the stages of development, what the G4 Alliance working group is aiming for, the different collaborations we have established, and where we are now and where we are heading. In my opinion, this is very important for the Latin America region as much as anywhere else in the world. This is how this fits into the G4 Alliance strategic plan. We are collecting or wanting to collect data. I love the terminology that says data is the compilation of 1,000 stories. So I will not address each area on this slide, but the Operative Encounter Registry is to raise awareness, hopefully guide policy, and result ultimately in resource mobilization. Many of you will be familiar with the Lancet Commission of Global Surgery. And on this slide, you see the 5 key points that came out of that. But the reality is that many of the assumptions and key messages in the Lancet Commission report of 2015 were generated from extrapolation of limited available data obtained in low and middle income countries. There is no big data set. that guided this. We have had, since 2015, 3 major resolutions that have passed through the World Health Assembly. The original one, 6815, one called 7222, which required each member state to report their progress, of 6815. And then last year, in May, the Integrated Emergency, Critical, and this new term, Operative Care. Again, a common thread in all of these is that member states, different countries, were urged to collect and compile data on the number, the type, and the indications for surgical procedures, and to establish mechanisms to collect what was in the original resolution called emergency and essential and emergency surgical anesthesia case log data. So collecting data from surgical and anesthesia procedures. But the reality in much of the world is this is how surgical data is collected. This is my hospital in Congo. It is a 350-bed hospital, but the data is collected on paper and then reported to various authorities. So this is a difficult way to progress if you are wanting to collect data from throughout the world. So this has become a key initiative of the G4 Alliance, working with the World Health Organization to develop a minimum data set on a digital platform so that we can prospectively collect data on SOTA care, surgery, obstetrics, trauma, and anesthesia care, and then it can be used for advocacy, quality improvement, and potential upscaling where that is necessary. But if we want this to be used in low and middle income countries and even high income countries, the working group had some various principles that we wanted to work towards. So firstly, the data set needs to be simple. Our long-term aim is that this would be collected in level 1 facilities, perhaps a health centre or health clinic where there is one doctor or one nurse performing surgery or C-sections. So it needs to be simple. It should provide some incentive for the end user to gain feedback on their own practice. To encourage them to use it. needs to be integrated into existing hospital systems where they already exist. So we have this term interoperability. And it needs to provide de-identified information to ministries of health of the WHO member states. And this important data would need to be housed in a secure server, which WHO has. The World Health Organization has been developing what they call a suite of registries. But they have asked us to particularly associate with the International Registry of Trauma and Emergency Care, because there is crossover between surgical care and trauma care. So just a small amount of history about this project. This was one of the first working groups established by the G4 Alliance. It was then called the Perioperative Case Log Database Working Group. And that is really what it aims to be, to collect perioperative data on the cases that are undergoing surgery, obstetric, trauma, and anesthesia care. The G4 Alliance saw this as necessary, and it was formed at the end of 2014 and beginning of 2015. So the working group was established early 2016. The working group had many members from throughout the world, and a Delphi approach was used to determine then 38 variables. That was piloted with 534 cases from 13 countries, a couple from Latin America. That occurred in 2016. Interestingly, half of the sites did not have any existing database, but everyone said they wanted to be collecting such data. This just shows the paper-based data that was being collected. Historical document. And I will not spend a lot of time on this, but it will just show you some of the things that we gained from that data. We knew the median age of the people being treated, that just over half of those undergoing surgery or obstetric or trauma or anesthesia care were funded by donation aid. We knew the ASA. If you move to the bottom line there, you will see that 90% of the sites that were surveyed was satisfied with the information collected, and everyone thought it was important and wanted to continue. But it also showed us in the second last line that there was variability amongst the data points that were collected, and there were certain data points that were not well collected. And this just gives a breakdown of those data points where there was greater than 90% collection, 50 to 75%, and less than 50%. So we have been through this before in the G4 Alliance. The second stage of this development started in 2019. For various reasons, there was a gap during 2018. But the working group was revitalized in 2019. It was at that point I became the co-chair of the working group. The original data set was reviewed, and we decided to find out who was working on collection of data in other sites in the world. And the yellow box shows some of the different groups that we corresponded with. At the same time, we were exploring e-platforms for the data collection. WHO had developed the International Registry of Trauma and Emergency Care to be used on a DHIS2 platform, which is District Health Information System platform, developed by the University of Oslo, and that is used in many low and middle income countries already. So 2019, we were progressing with that, as was WHO. Then COVID hit, and we continued discussions, but WHO were not able to finish their piloting of the IRTEC, the International Registry of Trauma and Emergency Care. But through these discussions, we came to the point where a specific surgical module could be determined. In 2022 and 2023, WHO started using the terminology operative in the lead up to their eco-care resolution that they put to the World Health Assembly in 2023. Emergency, critical, and operative care. Operative care is to incorporate surgery, obstetric, C-section, trauma, and anesthesia. It can be confusing in some other languages, but the main thing is that the point of entry, the main point of entry of the data will be at the time of the operative procedure. We developed a core set of just 25 variables. These we hope would be collected in all sites, even level 1 health centres. 12 of these were specific new variables that were not already in the ERTEC. We also developed an extended set of an additional 14 variables for institutions who had the ability to collect more data. So that 25 variables we hoped would be collected everywhere. A larger institution might have the ability to collect the additional 14. Sometimes we are asked, why WHO? They already have experience with developing the other registries. They work with the University of Oslo to use the DHIS2 platform. Importantly, they have independent housing and a secure server. So the G4 Alliance does not want to be the housing and the security of the server. That is complex. So we have an international multilateral body that has that already. And the plan for WHO was that they would have national registries that meet the reporting requirements of the WHA resolutions. So the surgical or perioperative collection would be part of their suite of registries, as I referred to before. They collect data on, for example, maternal registries as well. Their emergency registry is quite complex, has a lot of data around emergency presentations, A, B, C, D, E even, etc. So we hope that this will be a specific surgical module. I will just show you briefly some of this. Some of the key things or key data points in the core set are actually just identifiers. For example, an ID. But there are other things that look at the type of surgical intervention, the provider, anesthesia, monitoring. We have changed it a little since I developed this slide, and I will in a moment show you the actual database. So in 2023, we developed a demonstration project, as we call it. You could call it a pilot project, separate to WHO, to test the variables and collectability in 9 sites. You can see that it lists there South America. The Spanish translation form of that has not yet been tested. We are hoping that as a result of this presentation today, some of you may have sites that would participate in that. Because the DHIS2 surgical platform has not yet been built, we determined to use a form called JOT form. We set up a WhatsApp group to offer support to the sites collecting data. And eventually, when the Operative Encounter Registry is rolled out by WHO, we hope there will be a community of practice, a simple place where those using or collecting the data can communicate with each other for clarification. So the G4 Alliance WhatsApp group was to test how that might work. This is the JOT form, and you can see very simple questions that you could enter electronically. A large amount of data has been collected from one institution in Pakistan in the English form. And they have found it so helpful, they want to continue it beyond this demonstration project. So we are now moving ahead with WHO. We've almost settled on the data points because although we are gaining feedback from the demonstration project to tweak those, we have developed what we call audit filters, which will be those key data points and associations between data points that will give an understanding of the quality of care and where the upscaling can be, quality improvement. And the team that does the work for the WHO registries is actually currently building the surgical module. There have been some contentious issues. For example, the indications for surgery, the procedure list, the post-operative complications. WHO had asked us to use a referenceable list for those things. But there is no referenceable list except for fairly complex codes that are used by coders in high-income countries. Therefore, we are working through having something that fits with the guiding principle I talked about at the beginning of being relatively simple. When fully implemented, we hope that users will be able to see their own operative data, and they will also be contributing to de-identified global data that will enhance the advocacy for surgical health system strengthening. From the G4 Alliance perspective, you may know that we say we are advocating for the neglected surgical patient. But the aim is to have data that will tell the story of the neglected surgical patient. Because data is the compilation of 1,000 stories. I saw this sign at the UN General Assembly in September. And I thought that was very apt. We hope that the Operative Encounter Registry has the potential to fuel the progress that the G4 Alliance wants to see in soda care globally. This just shows you a work plan we have been working towards. We will ultimately, firstly, for the Latin American working group, we hope that you would be able to participate in the Spanish translation of the demonstration project within the next few months, because it is very important to know what issues we will run into in different regions of the world. So having Spanish translation input is essential to our overall development. That is the first appeal I will give to this working group, to please help us with that. Ultimately, though, when the Operative Encounter Registry has been developed on an e-platform, we will want to pilot it in different regions of the world. The ultimate aim is to have open access for widespread use. We are probably along a fair way from that at this point in time, but all of this groundwork we do is likely to ensure that open access and collection of data globally will be more effective in the longer term. So thank you for allowing me to, I hope that gives you understanding of the background. I will stop sharing this presentation and just share now the database that, as it's shown on an Excel spreadsheet, really just to show you how we have developed this. I will not go into it in depth. I'm quite happy to take any questions. You can see there are, in the blue, to the right of the blue, you will see that there are points that would be entered either in the core or extended set at the time of surgery, but they are recording data from prior to surgery. There is data to be entered about the encounter in the operating room, and a small amount of data to be entered after the operative encounter. Excuse me. Our feedback so far is that disposition on leaving the operating room is able to be collected. Disposition 24 hours after operation may be difficult, but probably doable. Disposition on facility discharge may be more difficult. I will just go along to this. Each data point then has a definition, which shows that you can use to enter the data. I mentioned the surgical intervention is a contentious point. We are constantly updating that from the feedback we are getting from the demonstration project. Here is the category of surgical provider. So I will not go through this in depth, but just to give you an understanding that the definitions have been developed and the different data points. It's probably better if I stop now, and if you have any questions that you want to ask me, and if JD can translate for me.
Well, Neil, thank you very much for your presentation. It's amazing to see all the work that you have been doing, with your team. I just have a comment. We are going to pilot with PAHO the tool that they develop, that they present in Bauru during this same meeting in Colombia. And it has different variables that I see, in some of the screens that you just mentioned. Those variables are also very well aligned with the Colombian healthcare system and the ministry requirements, because the data that Colombia collects is it's very, very good, actually. They had done a lot of investment in data collection with support of the CDC and PAHO in the last 5 years. So one of the challenges that we're trying to solve with the PAHO tool is, as you mentioned, the interoperability. And I think from that experience is something that it would be very important to assess with this tool that you present, as some of the variables you need are already in those other systems. So I think that would be very interesting to explore and see if there is a way to connect and to get that data and share that data as you are presented right now.
Thank you, Carolina. If you have access to that PAHO database, if you could send that to us, that would, if they are willing to share it with us, we can do a comparison. But you underline also the need of interoperability. We do not want people collecting data twice, but the data points that may be collected in Colombia that are relevant to the Operative Encounter Registry, we hope will just be scooped out electronically to provide the information for reporting from member states, etc. Compiling it with other member states to give a handle on operative encounters across the globe.
Yes, for sure. Well, I don't have the PAHO database. That's their property, but we will do the pilot, and for sure we will be assessing and providing feedback as the G4 Alliance group. You are welcome anytime to join, because as you already know very well, this work that you guys have done, then it's going to be easy to provide for them the feedback, because we are going to have, and maybe we're going to invite everybody to join when we explain how we're going to implement this project with PAHO, because some of our organizations, the G4 Alliance organization that had presence in Colombia, will join the local teams from PAHO and the health secretary, and they will collect the data on the ground, but also, of course, for surgical purposes. But all that process will be assessed, and also it will be used to provide feedback for this tool that PAHO has. So everybody's welcome to do that. So we will have our teams on the ground providing feedback from that perspective, right, about the data, our clinicians, public health physicians, and of course the G4 Alliance members. So that will be great to do. And the other thing that I think it would be very, very interesting, for at least for Colombia, because I know no all the Latin American countries are the same. There are others that the data systems is very different. For example, Brazil, we were assessing the data collection in Brazil, healthcare system data collection, and actually they have like 7 or 8 different ones, because we're working in the borders. So we took those data tools in order to see if we could share information within the borders. So we assess Peru, we review Brazil, we review some Ecuador, and we realize that the one that it's like more easy in terms that there are only 2 official major data collection things is Colombia. The other ones like Brazil had 7 and things like that. So in Colombia, that data is centralized. Of course, all the hospitals collect data and those things, but they had to report also to the national system. So we were doing that, and I think something that it would be very, very important for them is also to have the data from developed countries. I know you were saying that this is for like low, middle and low income countries, but for example, here in Colombia, the government is interested in compare themselves with more developed countries, because of course that's the goal, right? To reach what they have accomplished and to compare the data that what have been done with them. So not they sometimes do not want to compare those data of performance with other regional countries. So it would be also great to have that data from those countries. I think that would be interesting for them.
Thank you, Carolina, for that feedback. And I'm sorry if I gave the impression that we wanted to collect this data just in low and middle income countries. That is where probably there is the greatest need for upskilling, but we do want the data from high income countries as well. And as one person from the US said to me recently, we need this type of data collected in our setting as well. So it is something that we need to look at across the globe, but getting that Latin American perspective is essential.
Thank you, Neil. I'm going to look if there is more questions in the chat or if somebody else have comments. No, I don't see more hands. Any other comment?
Natalie has a question.
Yeah, just one comment that's sort of an observation after our first demonstration project. It's that the sites require a lot of support. They have a lot of questions about specific variables. They want to be able to meet and share feedback. And I would say Neil and Chris and I and the working group really tried our best to provide that support. But it was hard, and there's just a few of us and we're all in different time zones. But to really do this demonstration project well, the community of practice that Neil mentioned is really important. So I'm very hopeful that maybe this is something that this working group can help us with, to really provide good support to the sites to be able to answer questions quickly, to have places for them to give their feedback, so we can really be collecting, not just the data in the tool, but also a lot of the qualitative feedback about their experiences. So just, I guess, another comment that this is something that I would love for the two working groups to work together on.
Thank you, Natalie. That's very important, and I thank you for highlighting that.
Well, I don't see more comments, questions.
Yeah. Yeah.
I-
Can you hear me?
Yes,
This
yes,
is
Bart.
Bart. Yeah, it's really dark here. I'm in Europe, so it's already midnight over here, so it's really late. One question. Say I am involved with SOTAC Convoys. You might have heard with one of the G4 Alliance members, and we are going into Africa with a concept of mobile surgical care. But we do feel that for us, data collection is really important because we want to prove that with mobile surgical care, we can increase the access to surgical care. But we want to do it in such a way that we want to prove to governments that they can incorporate mobile surgical care in their NSOPs. But the question is, what's the best way to gather data on what we do? And what would be also, and of course, you might not have the right answer right now, but what would be the best way forward, how we can make use of the knowledge of the G4 Alliance to find a way to gather data that would really support our case?
Maybe, Bart, I have just a comment about that. So, because we do, I work for Operation Smile, and we have missions, right?
Yeah.
Surgical missions. So
Yeah.
how we call it.
Yeah.
To different regions. So I think in different 40 countries, right? So what we do is based on the legislation. So of course, originally we have our own medical record in the different countries, right? But
Yeah.
I belong to the policy and advocacy department. So what we want is to, of course, use that data for policy in decision making and to be aligned with the governments. So that's why we're piloting this data collection tool with PAHO, because as an NGO, I really don't know specifically about your organization, but maybe applies. Because what I was saying is that we as an NGO, we have our own medical record, but definitely, for example, we do not provide all the post-operative care, the follow-up that they need. They need to keep going to physiotherapy and those things. So they will be translated, no, sorry, they will be, the care of the patient will be complemented by the public system, right? Or the private system if they pay or something like that.
Yeah.
So in that way, that's where the PAHO tool comes, because this PAHO tool was developed to integrate the data of NGOs, not only health care providers, NGO, but also other kind of NGOs that provide, for example, transportation or food. Because, for example, for a patient to get to surgery, they need transportation. And then there is other NGO that will provide transportation. So this tool integrate all the information related to the surgery itself, provided by NGOs, and integrated with the Colombian public healthcare data that, as I said, it's integrated into big tools. So interoperability is what we're working now. And that's like how we are trying to respond to that question, to how to keep our medical records, being a private organization, but also sharing the data and providing, the data that the government and the WHO, in our case, PAHO, needs for decision making.
Yeah, but does it give you the possibility to measure how the situation is before you moved in and now you are in as Operation Smile? That you see the effects of your activities?
Well, in Colombia specifically, it does, because the data that the government already collect, right? That they collect, independently, without having into account. So they, for example, know what's the epidemiological data associated with, for example, appendicitis complications, and children born with different pathologies. So they already collect that data, and we have the other part, right, as NGOs. But we're not the only ones performing surgery. There is many other things. So that's why we need to articulate the data, and then that's when PAHO came, and we're joining forces with them, because we cannot get access as an NGO to the other data, right? Not even the public data or the other organizations' data. So
Yeah.
yes, so we hope to be able to do that comparison once we have interoperability of the data
Yeah.
sets.
And then Neil, do you see something similar in Africa? If we will be focusing on Eastern Africa, is there a tool already out there that we can look up to or link into?
The quick answer to that is there is no current tool. Individual countries are collecting some data, and this is where this would be a huge benefit. I'm going to speak hypothetically now, but where we see this could progress to, you may be able to identify, by collecting data across different member states, countries, regions, where the gaps are, because there is no access. And that is where you can then have your mobile convoys going into those areas where that access is poor. And you collect your data to show where you are filling in the upscaling. But it has to be worked in with obviously the local authorities. I think that's what Carolina was just saying.
Yeah.
But that's where I see this progressing to in the longer term.
Yeah.
But currently there is no such database, and that is why we need to all keep working towards this to strengthen the health systems in the individual regions and countries.
Yeah. Okay, let us crack our mind how we can fit in there. Yeah.
I was just going to add a couple of details, Bart, about the registry itself. Neil's correct. There's very little before data. So you may come in, and even if you are using this particular registry, you would only have what happened after, the patients that you cared for. But there are a couple of variables in the tool that are aimed at looking at that question of access. So, if there's a particular area that has been identified as really, people travel very long time to get to care. They often have a delay in receiving care. So there's one variable that asks about place of residence, which is really just kind of city, county level. So that can be done to show, based on your location, how far someone traveled to get there. And then there's also some timing variables. That's, times the surgery was rescheduled, when the original diagnosis was. So there may be some information, if you were to use this tool, that would start to show maybe an improvement based on what's sort of general information about access in that area. So just a couple of thoughts on specific variables.
Yeah, no, there are definitely some interesting angles to look into that we can incorporate, and knowing that we need to start from scratch, that we can learn from what has been done in other places.
Yeah.
And
another thing about the particular tool DHIS2 is that it's actually customizable. So specific facilities can create additional variables. So and it's open source. So if you had the kind of technical capacity, there's a way to research sites can add variables on top of what already exists in the registries. And sorry, Caroline, I interrupted you.
No. I wanted to add two things. One of the things that PAHO did is they incorporate georeferentiation. I think that's what Natalie is saying. So they georeferentiate the NGO that provide the service, and also they track not only the people, like for example, where they live, but also where they, the surgery was performed. Because as Natalie was saying, maybe they go to the doctor in one place, but they have to go to other bigger hospital in another city to perform the surgery. And also because we have a lot of migrants, and we want to see where the diagnosis was done and then how they get access. So they track all those things, because PAHO is not only focusing in health. Actually, they're not healthcare providers. They are more focused in protection and the social aspects of health. So for them, they have a different perspective about all the things that happen around the person, to get access. So that's very interesting. And the other thing I would definitely recommend, Bart, now that you are in a great point that it's zero, is to look at the indicators, the government indicators of the countries, because you want to definitely have your variables to answer that question, even if are not the same indicators for your organization that you would like to have. It would be very great to have those variables in your data set, because it's difficult to go back and then define those things. And also, of course, I think for me, the key is interoperability. Also to look, WHO indicators, of course, all the data set that, Neil showed that is very well defined, is variable. So having those definitions of, data sets that you already know exist and you want to match your data with is very important when you create your tool, right? Or with the engineers, how to collect the data, because I think it's more easy to do the interoperability thing than actually collect the same data from different sources. So
and I fully get it, Carolina. It's about finding the right parameters that will make sense. So it's not so much on the data collection itself. It's just how do we pick the right elements so we have the best benefits of our data collection. But that's something we should discuss with the local countries as well.
Yeah.
Hi. Just a brief shared experience. Thank you, Neil, for that great presentation. But we're working in Sucre in Bolivia, trying to implement and have the same question. If there's no data before, how do we measure that we made an impact? And I think the agreement is you have to begin somewhere. Even your being there is already changing things. So, assume that that's a thing. And just by beginning to apply, and if you return over time and you have a commitment of the people of the places you're going on these mobile campaigns, I'm assuming, you kind of return at least to some of them, you build relationships. If you begin somewhere with this sort of defining these variables, what you want to do, you might take a look at this registry. This registry is really great and very friendly in this form of the JOT form. And if you go there and then you have a commitment from that place or locality to keep on doing the data and you return, I think that over time is the only way that you might be able to show, if you do this, how does it impact either access or whatever you want to measure? How does it impact if we introduce an anesthesia machine? How is this impacting number of surgeries and the outcome of surgeries and things like that? I don't know. I think something, it's just a starting point. Sometimes it's just that. And then over time, continuing with that data, see if there's change and how you can show. Otherwise, you're kind of stuck.
Yeah, I agree. So step by step, and it's a small steps, and we just say celebrate the small
Yes.
parts as well. Yeah. Okay, thanks. That helps.
I don't know if there is more comments, questions. Well, I think we're past 5 minutes. So thank you very much to Neil again. This is a very, very great topic. I think, looking into the future is data, as you mentioned, it's very, very important for performance in surgery, for, making decisions and all what you have presented. Thank you very much, everyone, to join us. And I think we're recording this to share with more people. And I hope to look forward for our next conference next month.
Okay.
Carolina, thank you. And just to reiterate, we're very keen to have the whole Latin America region involved in this. It is essential that we do that, not just in the piloting, but then in the ultimate outrolling of it all. So thank you for allowing me to address your group, and feel free to reach out to the G4 Alliance or me if you have other questions or comments about, or want to look at the database in a greater detail.
Okay, thank you all.
Thank you very much. Thank you for the
Thank you.
opportunity.
Thank you.
Thank you.
Bye.
Bye.
Bye, Jody.
Bye. Thank you, Jody.